Thank you very much, Dr. Morel, for this great talk. Our next speaker, it's my pleasure to welcome Dr. Mark Hazekamp from Leiden University in Amsterdam. And he will be talking to us today about the European perspective with focus on the double root translocation.
I'm happy to present this from the Netherlands in Europe. It's 6 o'clock in the afternoon here, so good morning to you. I was asked to focus on the double root translocation. So I'm a pediatric cardiac surgeon. I work in the Netherlands and also in France. I have to explain that I do not have any personal experience with the double root translocation. I do have experience with the Nikaido operation, but just with the conventional Nikaido operation. I did 23 of these operations in a time frame of more than 23 years, so it's a rare operation. And in my personal experience, I do not detach the coronary arteries, only very, very seldomly. I do not detach completely the aorta, but I rotate it clockwise into the left ventricular outflow tract. Most of the cases, I do not transect the aorta, neither do I do a Lecomte, but I use a Contegra conduit that I wrap around to make a connection between the right ventricle and the pulmonary artery. So personal experience with the double root translocation I do not have, but I can tell you something about it. And to speak about the European experience with the double root translocation, we have to go to Austria, to the clinic in Linz. It's a small village, I've been there once, where Dr. Meyer started doing the double root translocation, and he has a big experience with this. So So I'm going to explain you what the double root translocation actually is, what are the indications, and then finally try to answer the question whether the double root translocation is better than the simple Nikaido operation or the posterior aortic root translocation. So what is a double root translocation? The technical principle is to excise the aortic and the pulmonary root together en bloc, rotate them 180 degrees and re-implant them after that. And then, of course, you have to enlarge the left ventricular outflow tract with a patch that at the same time closes the VSD. And Dr. Meyer and his group from Austria, they say that 2/3 of the pulmonary valves, in their experience, could be preserved and that they can demonstrate growth of the aortic and the pulmonary root in their material. So there are two variants of this double root translocation that were described. So separate pulmonary and aortic root translocation. This was described by Dr. Hu in 2007, but that is not the most common form. The first really double root translocation, so to excise them together and to rotate them and re-implant them together, was published by Dr. Yamagishi from Kyoto in Japan. And I will tell you a little bit more about that. Of course, there is a lot of semantics, and that's also true for the Nikaido operation, Nikaido, Beck's, posterior aortic translocation. But speaking about the double root translocation, we speak about this one, half-turned truncal switch operation or unblock rotation of the outflow tract. So that is complicating the things a little bit sometimes. But let us first start with the publication of the Dr. Yamagishi from Japan. This was published in 2003, and he called this double root translocation, he called it half-turned truncal switch operation. And it goes like this. You can see this here. So the aorta, the LVOT, and the pulmonary root, they are excised together, and then you can see here is the truncal block. Then it's turned around 180 degrees so that the aortic root is going to be exactly above the left ventricle, and the remnants or the part of the pulmonary valve that is still usable is going to be on top of the right ventricle. And then you see here in the next slide how this is going to be re-implanted. The aortic root, again, on top of the left ventricle. The coronaries, of course, have to be excised and re-implanted. And then what is left of the pulmonary trunk with the remnants of the pulmonary valve is put on top of the right ventricle, and this is completed with a patch. And of course, then a Hazekamp maneuver is necessary. And then the example of the people, the surgeons in Japan, was followed by Dr. Meyer and his group, and they published their first results in 2006. They called it en bloc rotation of the truncus arteriosus. So again, another name to make things a little bit simpler. And this is a drawing or a series of drawings from their publications. So again, everything is excised together, the aortic root and the pulmonary root, and then turned around. They do a Hazekamp, and then you see it here implanted. But in this case, sometimes they can use the complete pulmonary valve, not in all the cases, and then they can avoid the use of extra patch on the anterior side of the connection of the right ventricle and the pulmonary arteries. So that is a description. So first, the double root translocation was invented by surgeons from Kyoto in Japan, and then this example was followed by the people from Austria, the group of Dr. Meyer. So what are the indications for these operations? Basically, they have the same indication as most of the operations for transposition with VSD and pulmonary stenosis, and it's just one of the variants of surgery that is possible. Then the most important question, at least in my view, is to ask ourselves, is double root translocation really better than a simple posterior aortic root translocation or an Nikaido operation? There was an intent from Japan, from the group of Dr. Yamagishi by Dr. Hongu to answer this, and they published this in 2021, but they only compared their half-third truncal switch operation or double root translocation to Rastelli operations and one REV operation. So that does not really make much sense, because we know that there are important differences between the Rastelli operation and the aortic root translocations in all its forms. So this is not really helpful, this publication, I think. And there is, fortunately, another complication that was published in Europe, and with the use of the results of the group of Dr. Meyer in Linz in Austria, and a few other centers from Europe, we tried to answer the question whether aortic root translocation and so the simple, but the Nikaido operation and the en bloc rotation of the outflow tracts, to compare them in this multicenter study. And this was published in the Journal of Thoracic and Cardiovascular Surgery in November 2022, so recently. And this is what we found. The groups were comparable in terms of anatomical subtypes and associated defects. And there were 43 patients with an aortic root translocation, and 27 patients with an en bloc rotation or double root rotation operation. And the group from Dr. Meyer in Austria provided all these 27 patients, while the other 43 patients with the more simple form of aortic root translocations, they came from a few centers in Europe. And you can see the differences. To start with, the median age in the group of aortic root translocation was much higher than in the group of the double aortic root translocation, more than 1 year versus about 4 months. And also the number of previous interventions, usually Blalock shunt, sometimes a Glenn shunt that was reconnected later, was much higher in this group of aortic root translocation. So it's 88% versus 33% in the unblocked rotation group. And we can explain that because they, of course, are operated on a much younger age, which makes then sense that there is less need for prior operations. And in terms of mortality, the early mortality between both groups was similar. There was no significant difference, and also for the late mortality, it was similar. So there was no difference between mortality between these two groups. And but there was another thing, and that's I think much more interesting, but also a little bit concerning, because we have seen in this study that there was much more significant residual leakage of the aortic valve in the unblocked rotation group when we compared it to the simple Nikaido operation. So 60% of significant aortic valve insufficiency versus 2.6% in the Nikaido group. And this is something that needs some explanation. So more aortic valve insufficiency, and we are not talking about mild or trivial aortic valve insufficiency, but moderate or moderate to severe or even severe aortic valve insufficiency after the unblocked rotation operation. And on the other hand, there were less interventions on the right ventricular outflow tract in the unblocked rotation group, and probably because they did not use a conduit. When you use a conduit, as many people still do in the conventional Nikaido operation, I do that myself also, then of course you have to deal with re-interventions because of the presence of a conduit. And if you do a Lecomte operation and you use a patch, as was shown earlier by Dr. Morel, then of course the number of re-interventions is less. I use personally bovine jugular vein conduit, the Contea conduit, and my first patient, he had a 16 millimeters Contea conduit, which is remarkably still in good order after 23 years. Of course, we had some other re-interventions for Contegra change and one case of endocarditis, but sometimes this works really well. But if we go back to the topic of aortic valve insufficiency, so the people from Austria, the group of Dr. Meyer, they speculate that oversizing the VSD patch may be responsible for this, and they claim that in their later experience, the problem of aortic valve insufficiency may be a little bit less, so the results are better. In my personal view, I think the more you detach, if you detach routinely both coronaries, and when you always transect the aorta, then of course you can get some distortion of the aortic root, and this may also be responsible for the problem of aortic valve insufficiency. And the other question is, of course, what is really the use of the pulmonary valve? In their experience with the unblocked rotation operation in Austria, they say that 2/3 of the pulmonary valves could be preserved. And so that is a little bit contrary to my experience in all the Nikaido operations that I have done. I think it is really difficult to say that I could have spared 2/3 of the pulmonary valve. So I don't know. If you can do it, of course, it's fantastic. But this is a little bit contrary to my own experience, and I think that other surgeons also uh, do not always think that they can remain with a good pulmonary valve and a good pulmonary route. So I think we have come to the end of this presentation of mine, and I think we will have the questions a little bit later. Thank you very much.